Dr. Coleman, Dr. Davis, it's an honor to be with you both today for a discussion on a topic that I know all three of us care very much about. The issue is health disparities and how we as policymakers, as physicians, as people who care about the quality of life in our communities can improve healthcare for people of all backgrounds. And I know I've been struck throughout my life by the disproportionate impact of asthma on Black communities. And recently, through the work and my exposure to the work of FAIR and FAIR's work on diversity, equity, inclusion, and access, I become much more aware about food allergies as another aspect of people's health where people of different backgrounds face different challenges. I mean, food allergies affect every community of every background, and yet some communities have greater awareness about it. Some communities have greater access to treatments. Some communities are included in research more regularly. And these are some of the issues I'm hoping that we can talk about today. But first, let me just check in on the two of you. How are you doing today, Dr. Coleman?
I am doing great. Thank you so much for this opportunity to have this discussion today. As you mentioned, health disparities are something that I'm very passionate about. And I too agree that with regard to food allergy disparities and access, increasing awareness is something that we definitely need to do. And this conversation is going to be very helpful for that. And I'm grateful to be a part of it. And I'm excited to speak more. So thank you. Thank you for having me.
Thank you, Dr. Coleman. Let me ask you, Dr. Davis, let me check in quickly with you. How are you today?
I'm doing very well. Thank you very much. I'm also, just like Dr. Coleman, and really pleased to be here having this discussion right now. I think during this time, during COVID-19, it has really brought to light health disparities. And so I think this is such a pertinent discussion, and I'm glad that we're going to be talking about ways in which we can really improve access and involvement of underserved populations.
Thank you. So sticking with you, Dr. Davis, how does this play out in your own practice with the patients you serve and the families you serve?
Well, it's interesting you asked that question because the patients that really moved me to focus on research in food allergy were patients from minority backgrounds. I remember one particular patient who had severe skin allergic disease, atopic dermatitis, as well as multiple food allergies. This patient had multiple anaphylactic reactions in daycare, and the entire family dynamics changed with the mother who was wanting to have an higher education and a degree, dropped out of school. And this really impacted me to let me know that food allergies is a very significant disease that has enormous effects on quality of life. I also noticed during my practice that epidemiologic studies show self-report of food allergy in minority communities was very high, but diagnosis was low. And so because of that disparity, I did want to make a difference. I work at a tertiary care hospital. So in many cases, I actually see a small number of under-resourced minority patients, but I do know that that is not everyone who has food allergy. There's a disparity there. And so we need to increase the access to those patients.
And why do you think diagnosis is low?
There are a few issues that really contribute to this. I think one is that the primary doctor of patients may or may not be familiar with how to recognize food allergy. They may not have the access or know of a way to refer to allergists in the community. That's one reason. There needs to be more collaborative relationships between allergists and primary care physicians and providers that serve underserved populations. Additionally, sometimes there are barriers to actually getting that referral to a specialist. And then we know from studies that once underserved populations that have public insurance versus private insurance actually get to the specialist, it's interesting, the diagnosis of food allergy has been shown to be made less frequently in publicly insured patients compared to privately insured patients. So there are several factors that are playing a role. I do think it is education that's needed, and then relationships between physicians and specialists, primary care providers. And then thirdly, just an awareness of allergists and the patients to know that this is an important issue.
Great, thank you. Dr. Coleman, how does that correspond with your experience with your practice?
Yes, I definitely echo Dr. Davis's remarks about presentation of food allergy. In my practice, I see a broad range of types of patients with regard to racial and ethnic backgrounds, socioeconomic status, and I definitely see quite a large population of underrepresented minority patients with food allergy. In my practice, I definitely see that patients from these groups will sometimes present later with food allergy diagnoses. And I agree that there may be a reason, maybe because of awareness in the patient population itself. Anecdotally speaking, I do find that certain groups of patients may self-diagnose their allergy and also try to self-treat, as opposed to presenting this allergy or reaction history to the primary care provider, and also educating the primary care provider about what a food allergy diagnosis entails and when it's appropriate to refer to a subspecialist is important as well. So I definitely do see disparities in my population based on a number of factors, including the patient's background, underrepresented minority groups, also with regard to access as well. And so some of those things are evident in our practice, and we're working to try to address some of those disparities that we see.
Dr. Coleman, when you say that your patients present later, does that mean that they come to you later in life after they've been suffering for many years with food allergies? Does that mean that they come to you complaining about other problems and it takes you longer to figure out that actually there's an underlying food allergy that may be causing it?
That's a great question. So these patients often present later in life than other patients do. And that can be for a number of reasons. Sometimes the food allergy isn't recognized by either the parent or the primary care physician. And sometimes these patients may not be referred to an allergy specialist to be diagnosed with the food allergy. We do know that early diagnosis of food allergies is important. It could be helpful in preventing lifelong allergies in the pediatric population. So the earlier that we're able to identify food allergies, the better outcomes we have with regard to management. So I definitely see patients from certain groups presenting, later in life than we would want them to compared to other groups of patients with food allergies.
Dr. Davis, you're a pediatrician. what's the conversation you have with parents that come to you as you help to educate them about the issues related to food allergies?
In many cases, I have a conversation where the patient or the parent tells me about something that's happened, either a rash or a cough, runny nose, or hives after a food has been ingested. And in some cases, I just want to highlight this education piece that that Dr. Coleman mentioned. They'll say, "Oh, we gave Benadryl and it went away," or they'll say, "I gave the albuterol and it went away." But we know that those symptoms are indicative of food allergy and need further follow-up. So sometimes when we have the discussion, I do need to educate about how to avoid the food, how to really make sure that this is the food that's the culprit, and the importance of really getting to the bottom of the issue. I was reflecting on the fact that Dr. Coleman mentioned that patients present late or are referred by physicians later to allergists. And one of the items and issues that have come up recently in my practice is the problem that patients that have Medicaid, so public insurance, actually are not seen by many allergists in the community just because the reimbursement rate for the services given to those patients is lower than private insurances. And so this, I believe, is really a huge problem. And I know you're in public policy, that I believe if there were changes on an institutional level in order to reimburse allergists for their services for patients who have public insurance, then more allergists would be available, access would be improved, and I do believe the patients would be better served.
And do the allergists have the right therapies available to help populations? I mean, how good is our science right now on food allergies in terms of treating them and treating them for diverse populations? I'll start with you, Dr. Davis, then we'll turn to you, Dr.
Sure. We're pretty good at diagnosing food allergies. There are 3 ways to diagnose food allergies. The worst way is just by self-report or history, where someone says, "I have a food allergy." We really, in order to get to the bottom of it, really recommend testing. That testing can be through a blood test for a specific allergy antibody to the food, or it can be skin prick test, which is typically done in an allergist's office. Using the symptoms that we glean from the patient and the patient's family, plus those testing results can, in many cases, give us a really good idea that the patient has food allergy and allow us to diagnose food allergy. Occasionally, there are some ambiguities in that process. And in some cases, what's the best test for food allergy should be done, and that is an oral food challenge in an allergist's office. That is the gold standard, and that does definitively let us know whether a patient has food allergy or not. So there are several things that can be done to rule in or rule out a food allergy.
And before we get to you, Dr. Coleman, which aspects of that are covered by Medicaid? Are all aspects covered? Do you know?
Yes,
I don't mean to put you on the insurance question here.
They are. That all of them are covered. The problem is that the doctor doesn't necessarily receive the same payment for the office for doing those procedures from Medicaid as they do from other private insurances. So the doctor may have to take a loss, right, from giving the right treatment to the patient, and that's what allergists would do. They would give the right diagnostic test and then do the right thing. But then they would take a hit, if I might say that, financially for treating and seeing that patient. So allergists must make sure that their practices stay afloat, and so they have to have the right mix of private and public insured patients just to survive.
Is that consistent with your experience, Dr. Coleman?
Yes, I definitely agree with Dr. Davis's comments. One of the things that I wanted to mention was when she was talking about diagnosing in certain populations, there are certain symptoms that the primary care provider or the family may notice as an allergy symptom, but in our practice, sometimes those patients don't present until they're having more severe symptoms that require a presentation to the emergency department. And a lot of our underserved patients are initially diagnosed that way when they present an anaphylaxis because of a food-induced allergic reaction. In our practice, we've also been able to recognize that although those patients present to our emergency department and from there are referred to an allergy subspecialist, they sometimes will never see an allergist, even though they have been, diagnosed based on presenting to an emergency department with anaphylaxis. And so, that's definitely a disparity there for a patient to be diagnosed with a food allergy and not be followed regularly by an allergist. The other thing I would also echo is that we also realize that Medicaid might not reimburse as well for certain procedures. And as a result of that, that could also be a reason why in our population, in our clinics, we may not see patients presenting to the subspecialist. Also, I work in an academic medical center, and we see publicly and privately insured patients with food allergies, and there are only so many of us in the academic medical center, and it can be challenging for patients just to get an appointment, to see the subspecialist. That can be a little bit difficult. So the time to care is a challenge, as well as access in our area. Some patients live in the urban area, but then we have patients who live in more rural areas, and so access to an allergy subspecialist can be challenging in that population as well.
So these are some of the disparities you experience in the clinical context and treatment of patients. And we know, of course, that these disparities extend to the research side of things as well. Maybe you can talk about, because I think you're both in the FAIR clinical network, also as researchers. And maybe you can talk about your experience, Dr. Coleman, with the disparities on the research end of addressing the food allergy challenges for this country.
Yes, I can definitely talk about that. At the beginning of the broadcast, you did mention about awareness regarding asthma disparities, but there is research being done to address disparities in food allergy as well as therapies for food allergy, and being able to recruit a diverse population for those type of studies is important for understanding mechanisms of disease and best treatments to have a representative sample of the population, and also to improve outcomes for our patients and families with food allergies. In our practice, we participate in therapeutic studies, therapeutic trials for food allergy management, and we also participate in studies that address more of the social and economic impacts of food allergy in different races of children who are diagnosed with food allergy. And anecdotally speaking, I will tell you that with regards to recruiting for those studies, we definitely do see differences with regard to the types of patients that are very willing to participate in research studies for food allergy, and those families who are not willing to participate. And so that can be a little bit of a challenge with regard to, just recruiting in and of itself for any research study. And also, this is the same similar thing that we see with regard to the food allergy trials and food allergy studies that we participate in. There are some things that our institution, and also in collaboration with other institutions that we conduct research with, have done to try to improve that particular disparity so that the groups of patients that participate in trials are representative of the patient population. So, that's one of the big kind of gaps that we see with regard to our food allergy research in our institution.
And have we learned any strategies or practices for trying to increase the enrollment in clinical trials for diverse populations? Dr.
I
Coleman,
would say in
stick with
our
you for a minute.
institution, sure. In our institution, some of the good things that we have noticed as far as strategies are that one, it really seems to help if the provider and or the person recruiting for the study kind of looks like the patient that we're trying to recruit. Also, in my patient population, we notice that if I have developed a relationship with the particular family of the patient that I'm trying to recruit, that helps as well, as opposed to an initial brand new patient who's coming in to see the allergist for the first time. Additionally, giving information about how the study not only is going to affect the individual as well as that individual's family, but also the broader food allergy community has seemed to be helpful for our patient population. Even our young pediatric patients who are participating in research, they like to know if this particular study doesn't help me because I'm on placebo, I want to participate because it could help another child who has food allergy. And so being able to educate, again, that piece of education is very important. Being able to educate the patient and the family about, yes, the importance of the research for them individually, and also the importance for the food allergy community as a whole, has been helpful in recruiting for our institution. It's also, I've noticed that a lot of families don't realize that there are disparities with regard to food allergies specifically. When just asking them, do you know that children who look like you have poorer outcomes because they have food allergy, or they may have more severe symptoms just because of their diagnosis? Families just don't know. So being able to give them more information is helpful. And having funding for more research that targets food allergy disparities is very important because, as you mentioned earlier, there's lots of information about asthma disparities and other chronic conditions, but we just don't have as much information regarding food allergy disparities. And so being able to do more research with regard to disparities in food allergies is going to be helpful for continuing to improve outcomes. So those are some of the things that we have seen that helps patients understand that this is an important endeavor and be able to recruit patients from underrepresented groups.
Dr. Davis, how have you worked to address either issues in clinical trials or other aspects of disparities in the research domain? And have you learned any best practices or strategies that have been most effective?
Yes, well, I would say that many of the same strategies that Dr. Coleman and her institution have used have also worked at our institution. We know that patient and provider concordance with regard to ethnic or racial background has really helped us be able to recruit patients. We also know that the trust factor is just huge. Um, we know that in the past, in 1930s, the Tuskegee experiment, which took 600 Black men and observed them with syphilis infection, even though there was a treatment available, as well as the Henrietta Lacks story, where a 30-year-old Black woman who had cervical cancer had cells that were used for experiments without her knowledge or her family's knowledge. And there was a real profit off of that. These two examples alone really fuel a distrust, especially in the African American community, for research. Whenever I bring up research with patients that look like me, they are always suspicious, and we have to address that. So education and a building of trust is absolutely essential. I believe the best research studies that have been performed use research workers on a team as well as providers that can really relate to that potential family or participant. The other issue I would bring up is the economic factor. Many of our families work, and they really can struggle if they need to come to research visits very frequently and are not given transportation, reimbursement, or some compensation for their time. It definitely is something that must be considered when recruiting patients for research studies. We have to really evaluate the effect on the entire family. And Dr. Coleman mentioned how the research will affect not only that subject, but the entire patient unit. So I would agree that these three factors are extremely important and have been able to help us recruit patients of diverse backgrounds.
I'm really glad to hear you talk about the trust factor and how critical that is. Because I think, and the Tuskegee experiments as well as Henrietta Lacks are examples of when that trust was broken. And it puts a real burden on doctors like the two of you, both in your patients, but also thinking now in the clinical network and the work of FAIR, how do we go about rebuilding that trust? Because to have effective food allergy policies, to have we're going to need to include all aspects of society. People are going to need to know they can trust the test. And I think, the example, Dr. Coleman, of, are people willing to know they might have a placebo if they have confidence that they're contributing to a system that can make both themselves safer and healthier, and their families and their children and their children's children. And building that trust is a long-term project. In the research you've done, Dr. Coleman, have we made progress rebuilding trust? And in the communities where you work? I know on a personal basis, I'm sure you do, but how do we institutionalize this? And where have you seen this? Which hospital systems, or which diseases, or which environments, or which subsegments of populations have we seen the most progress restoring this trust?
Yeah, I would say that we still have work to do with regard to restoring trust in research endeavors in certain populations. And I also would say that I agree that it is a long-term endeavor that requires an approach from everyone involved, and that is basically everyone in society, because improving outcomes for one group is going to benefit all of us, really. I would say that on a micro level, being able to be as transparent as possible with the study participant and their family about what is happening and what is going to happen is very, very important. Also, just frankly asking them about any hesitations that they may have and the reason why, and not making any assumptions and addressing those have been helpful for rebuilding trust. There have been studies that look at including other, I would say, members of the community in research endeavors outside of only the healthcare team. So implementing religious organizations, for example, or policy or advocacy groups as well, that also advocate and enforce the knowledge that we do understand that there's mistrust, and these are the ways that we're working to improve that, are very important. So I would say that it is a collective, it should be a collective effort for improving trust globally. And it just takes, one patient at a time, one study participant at a time, but being as transparent as possible and potentially utilizing other groups like FAIR, for example, to also work with the healthcare team in those types of endeavors and kind of building that.
And the issue that Dr. Davis talked about this patient and provider concordance, and you talked about this too, having doctors who look like their patients, or even other researchers who look like the research subjects. Have we made progress on that front?
I also agree that there is work to be done on that front as well. Just in the United States, we know that the diversity of just physicians in general does not reflect the general population with regard to minority groups. And that's even more evident when you start to look into subspecialties like allergy and immunology, for example. So, when I was in training, I didn't see very many allergists that look like me. And, that's a reflection of work that still needs to be done with regard to, making STEM very interesting for kids, and also improving our representation in medical schools and residencies and fellowships, with regard to all levels of our training, making sure that diversity and inclusion is incorporated in all aspects of that process. That's important. So in my opinion, I think there's still work to be done with regard to that particular issue as well.
I would also agree. Yeah. Although Black and Hispanic population in the United States is about, I would say, about a quarter. So about 13 to 15% of all U.S. populations are either Black or Latinx. We know that physicians are about 5% Black, or 10% Black and like Latinx, but about 5% Black physicians and 5% Latinx physicians. So there's a huge disparity there in just the medical field in general. There is this disparity. And then among academic medical faculty, 3% are African American or Black, and 3% Latinx. So really, there is an underrepresentation, and there are several things that really would need to happen in order for that to change. And Dr. Coleman mentioned some of those. Recruitment is important. I do think for the listeners, it would be important to understand that this really permeates our society, this disparity, and it can be really insidious in that studies have been done that show patients that come into an emergency room, you check the bias of the physician. There's a clear pro-white, anti-Black bias. It's been proven for adults and children in that setting. There have also been studies that show implicit bias in applications to medical school, pro-white, anti-Black. I just think that it's really something that would need to be tackled on an individual basis. I encourage anyone who's never taken an implicit bias test or implicit association test to take one and to learn about one's own biases, because this bias among physicians and their patients isn't necessarily only in kind of white physicians. It occurs across all physicians in society. So I think there is a lot of work institutionally to be done. I think everyone on an individual level can do something. And I do think that more programs to recruit these young high schoolers, college students into the field of medicine, and then also programs that really encourage people, young medical faculty, to continue in academics and in research are really important in order to make a difference.
Yeah, one of my colleagues at the Batten School here at the University of Virginia did a study about doctors' perceptions of the pain tolerances of their patients. And the racial disparities here are extraordinary and terrifying. The assumption that Blacks don't feel as much pain, and so they're not given as much pain medication. And the data is very compelling that we have a lot of work to do, both at an individual level, as you say, Dr. Davis, but also institutionally in thinking about how we are educating medical professionals, how we're recruiting. And I'm struck in this whole conversation that although we're talking narrowly at some level about food allergies and disparities in the research related to food allergies and the treatment, how it really affects the whole aspects of the health system, whether it's trust, whether it's representation across the medical field, whether it's medical insurance or health insurance and the payment rates for the academic bias and the academic research that's done. So this really, in some ways, food allergies are the tip of the iceberg or a canary in a coal mine for a broader set of issues that we need to be tackling together. And I imagine that's been true in your experiences where, a little disease is one thing, but actually it shows issues in the household, issues of education, issues of awareness, and the whole range of things. So it means that when you treat your patients, you're not just specialists on one narrow topic. You need to take the whole patient's perspective. As you've gone about that, and as you've developed, and as you've seen the field start to change, what gives you hope about the future of healthcare in this country? Now, of course, I'm asking this question in the midst of a pandemic. So you can comment on the pandemic, or we can imagine a point where we're defeating this pandemic. But what gives you hope in treatment of patients and dealing with health disparities? I'll start with you, Dr. Davis.
Yeah, I think just having this conversation on a national scale gives me hope. There are many people that are now thinking about disparities. They're thinking about health disparities. I've seen changes at our institution. We're talking about implicit bias. We're giving support for faculty. Where actually I've seen across the country where financial resources are being given for the training of young people in the STEM fields. And this all gives me hope that what has been really under the surface, I believe, for a long time is now being unroofed. It's being recognized. And I do believe there will be meaningful change for the thousands of children and adults in the United States with food allergies because of what FAIR is doing. So that is what gives me hope, and I'm just the awareness is incredible.
Thank you. And Dr. Coleman, what gives you hope?
Yes, I do echo Dr. Davis's comments. Even though the two of us have been very passionate about healthcare disparities and food allergy disparities, I feel like the COVID-19 pandemic has brought more awareness to health disparities and improving health equity for food allergic patients, as well as all patients. And I think having that awareness brought to the forefront definitely gives me hope. More people are being able to be heard, and that gives me hope. Also, understanding that there are things that we know that need to be improved, and we have taken some steps to be able to start to improve outcomes for families also gives me hope. So I feel that we're going in the right direction, and in the long run, we're improving the lives of many people because of all the things that are happening. And I'm very happy that FAIR has made diversity and inclusion a priority because it's important for individuals with food allergy and also for our communities. So all of these things that increase awareness, which in turn are going to be able to increase our management and treatment and outcomes for families, gives me hope for what's to come.
Well, the two of you give me lots of hope as caring physicians, as conscientious researchers, as advocates for greater equality in the treatment of patients and in the research process, and in your work with FAIR and the clinical network, and working to elevate the awareness, take this from being invisible, I think as one of you said, to something that is on the agenda, so that we can improve the quality of people's lives and help make a world where all people can thrive. So I'm grateful for your time today, and I look forward to the chance where we can have a conversation like this, sitting on the same stage, face to face in person. And before too long, we'll get there. Thank you both very much.
Thank you very much
Yes,
for having us.
thank you.